So real quick, let's do a recap from lesson 9. Lesson 10 today, we're going to do some headache stuff. It may say lesson 11 in some cases. The next one for us is going to be tomorrow. That's a short one. It's only going to be about 1 hour, and I think the juniors had some ability to get out earlier. Or is it the sophomores can get out early? Yes. So for you guys up early, just plan for that to be less than an hour. Farm's going to move up a little bit, so we'll be fine. We're just going to cover some of those brain bleeds and concussion a little bit more tomorrow. Short class because we've hit most of it already. Today we're doing headaches, but last time we went over different types of strokes, different type of vascular malformations. I made a couple of kind of recap slides just to make that easier for us and kind of group some things together because I know that was a pretty dense lesson. It was a lot of very high topic things. Most of the stuff from here on out, it's a lot easier. We're through the thick of the course at this point. All right, so last time we covered TIA versus ischemic stroke versus hemorrhagic stroke. TIAs, that sort of happens really quickly, resolves within 24 hours. It might not be a complete loss of blood flow, but we see kind of a decreased perfusion. We treat that as a warning symptom. We should still do the full urgent evaluation. If you look here under the common stroke symptoms, it's common across all of them. Clinically, can I differentiate an ischemic stroke versus a hemorrhagic stroke versus a TIA just by looking at somebody? Not clinically, no. I'm gonna have to look in and say, all right, let's get a CT scan, see what's actually going on here, or clinically see the course of it and see things resolving. That's gonna put it into one of these categories. All right, with ischemic stroke, we're thinking from 3 different sources. That can be thrombosis, which is where I have a locally developed clot that's causing issues. I can have embolism where it travels from somewhere else, and I should look to the heart for AFib or other common sources where I develop clots. And then I can have that systemic hyperperfusion. That's someone that, hey, we tried to do CPR on them, it didn't work, and they were anoxic for too long. That's going to present very diffusely. Ischemic stroke is going to be my more common one. About 80% of people are going to fit in this category, and that's typically my older folks that have a lot of vascular disease. Hemorrhagic stroke, that's the more lethal of the two. That's younger people, 40s, 50s. Something happened to them to cause a brain bleed to happen. And we'll go into those a little more detail. That's just a good wrap-up slide to differentiate them as we go. Ischemic stroke, we spent some time on that. I like this one slider because it kind of summarizes a lot of that stroke pathway for us. But initial steps, we treat it as time sensitive, figure out when their last known well was. We determined their last known well. We assess stroke disability using the NHS scale. And then we can do a non-con CT to see if we're dealing with ischemic or hemorrhagic stroke, because that definitely changes what our management's going to look like. And then typical management timelines, anywhere between 0 to 4.5 hours. It's a pretty good chance I can get breaking down clots without too much risk. That's pretty good for us. If we wake up and we have a stroke, or it's been more than 4.5 hours, I'm going to need some type of advanced imaging to tell me, hey, I still have reperfusible tissue. Because if I give you something to break down clots that causes a rebleed, that can be way worse than trying to revive tissue that's already not working too well. If I have large vessel occlusion, think that basilar locked-in type syndrome where, hey, something very large can be removed and cause a lot of advantages for us. That can be done out to 24 hours. And if not a candidate for those, we're going to continue to monitor them. We had a couple of different BP targets. I'll give you guys this. I'm not going to test you on specific BP targets and give you exactly this. You're not going to see a PANTS question like that. It's very specific when you're dealing with different guidelines for which. I just want you to know general strokes of what we want to do with blood pressures. So what happens to our blood pressure when we have a stroke? It increases, it goes up, because your brain's trying to reperfuse itself. It's trying to say, hey, I'm not getting enough blood for what I'm seeing, give me more blood flow. So you may see some sky-high blood pressures. We allow that to happen because the brain is naturally perfusing itself in ischemic stroke, because I'm not worried about bleeding happening. So no thrombosis, do that permissive hypotension or hypertension, allow that systolic blood pressure to go up to 220 and that diastolic to go to 120 before we start controlling that back down. If we want to give them lytics of some variety, bring them back down to a reasonable 185 or 110. And then we have a couple of contraindications for thrombolysis, cases where, hey, if I give them, it busts clots everywhere. If they've recently had a GI bleed, a major surgery, please know these contraindications. I will test on someone that has various degrees of contraindications versus not. Pay attention to these big strokes of this. And then lastly, the supportive inpatient care. We're controlling things. These are my people that we weren't able to do thrombolysis for, but control the temperature, antipyretics, resus as needed, manage the blood pressure, and manage the increased intracranial pressure because we see a lot of swelling with stroke. We had a couple of different varieties of stroke. I'll just kind of go over these real quick to highlight the things that I will ask questions on. Go ahead. It should be the recap that's in there. Do you have it? Okay. All right, so middle cerebral artery, that's going to be that most common one. More commonly, I'm going to see face and arm weakness compared to my legs. And then I'm going to have it be the contralateral side. So if I'm thinking right-sided, middle cerebral artery is affected, most common. Left side, I'm going to have arm weakness that's worse than my leg. And then we can have some aphasia if it's happening on the left side, or hemispatial neglect if it's happening on the right. Moreover, I want you guys to pay attention to upper versus lower, left versus right. That's going to clue you in a lot more. It's not always guaranteed that their dominant hemisphere is going to be one or the other. More clue into which side's showing weakness, because that's going to show you which side the stroke is on. We talked about the anterior cerebral artery, the Affordable Care Act, the ACA, and this one's my legs are worse than my upper extremity. I may have personality changes. I may have that urinary incontinence. I think, hey, ACA, Affordable Care Act, thanks Obama, I peed my pants. It's a strange thing for an instructor to say. That sounds like a personality change to me. That's urinary incontinence, and for my pants, that's legs down is worse. If that's a helpful mnemonic for you guys, I don't know. But with the anterior cerebral artery, think legs being more affected. That's going to be your key to localizing that one. Posterior cerebral artery, that one's pretty easy. We know it's going to that occiput that controls vision for us, so we're expecting some type of visual field deficit. Is that going to be that bitemporal hemanopsia? No, we think of that with pituitary gland. Is that going to be that weird pie in the sky where we start thinking Myers loop? No, we're starting to think hemanopsia. Left side of my vision is out, therefore I'm worried about right side of my vision is out, I'm worried about a left-sided posterior cerebral artery stroke. And then we talked about basilar artery real quick. That's the scary one. That's that locked-in syndrome. That's a patient that's suddenly catatonic, but their eyes are moving. This is people that can still sense and feel everything and still have thoughts. It's very hard to recognize this one. And lastly, we talked about lacunar infarcts as far as like our ischemic strokes. Just pay attention to these slides. These are the high-yield ones. The key to differentiating these ones is going to be kind of a slower onset over time. They come in, they have weird neurologic symptoms, they go away. They come in, they have weird neurologic symptoms, they go away. These ones have no cortical defects. That's going to be no agraphia, no neglect, no visual field cuts. They're not going to have aphasia because it's affecting more of the central ports of the brain. So we're going to see pure motor, pure sensory, or ataxic hemiparesis. These ones, they're slow over time because, again, we're affecting these small ones that don't affect the cortex of the brain itself. We also talked about hemorrhagic stroke real quick. Again, the initial steps, ABCs, do the basics. But again, get that non-contrast CT a lot sooner than you'd think because that, again, changes what our management is going to be. If I have someone showing up with a hemorrhagic stroke, I can give them thrombolytics and resolve their deficits, right? No, if I have an active brain bleed, I'm not going to want to break down clots. That's going to dramatically worsen the condition. That's why we have to break them down into, hey, is this an ischemic stroke or hemorrhagic? Because my management changes dramatically. Two flavors that I have is that intracerebral hemorrhage, that's where it's occurring within the brain parenchyma itself. Is there an easy surgical target when it's like inside the brain tissue itself? Can a surgeon clip something in there? Not usually. That's going to be more managed conservatively. Maybe they'll do something for intracranial pressure if that gets too high, but not an obvious surgical target. Those ones we're going to manage blood pressures. What if I have that subarachnoid hemorrhage, kind of outside of the brain itself? Maybe an aneurysm has popped. Is there an obvious surgical target there? Yes, because I have a vessel that's bled. I can secure that. Be it clipping or be it where they put the coil inside it, coiling. Both of those are very good options, and those will significantly improve outcomes for us if we do those. We have some blood pressure targets. Again, for the people that weren't listening before, do not memorize specific blood pressure targets. There's a billion different ones. There's so many great test questions to ask. I'm not going to get that far into the weeds with it. But just for your own awareness of what we like to do. If we have a very high blood pressure, I want to bring it a lot lower. If you notice our hemorrhagic strokes, we actually go for lower targets. The reason being, I have something leaking. I don't want to allow too much pressure in there because that's going to worsen the bleed. But as soon as I get that aneurysm secured, I go to that permissive hypertension again. I allow that blood pressure to ramp up to 220, so that way the brain's perfusing itself. Because I locked off where that leak was, I'm not worried about that leaking anymore. A couple of other details in there for you to go through. I won't belabor the point too much. And just for the visual people of like the different types of brain bleeds that we're talking about, we were talking about 3 and 4 yesterday. Subarachnoid hemorrhage occurring in the subarachnoid space here. There's a lot of volume for that to localize to. What happens when we have a subarachnoid hemorrhage? Is that going to be very easily localized to one spot, or is that going to cause a lot of weird deficits all over the place? All over the place. So when we're thinking about, hey, MCA versus ACA, Affordable Care Act, something about peeing my pants, when you start trying to localize lesions, think more ischemic. Don't worry so much about the hemorrhagic. Hemorrhagic is going to present with a lot of like sudden onset of like altered mental status. They're going to become untended very quickly in these patients. It's going to be hard to localize because the blood spreads everywhere. It's very noxious. And then lastly, this one's a quick, easy one. Just pull this topic out and move on from it. There's not a ton here. AVMs, this is the scary one, right? Because I have a vein connected directly to an artery, I worry about aneurysm in those cases. I can have developmental venous abnormalities, cavernous angiomas, telangiectasias. Am I as worried about those cases? No, I'll see them pop up in MRIs all the time. If something's changing or doing something different, we're having like a weird, like, hey, he has this plus seizures, maybe it warrants more evaluations. If these are incidentalomas, don't worry about them. AVMs, do not treat them as stable. There's no such thing as a stable AVM. All right, that does it for the review. Sorry, there was a lot of content in the last lecture. These next 2 lectures are a little more straightforward for us, which is good. I know the last 2 were kind of painful. We'll make sure we hem it in a lot better in the review for you guys. But today we're going to be talking about headaches and facial pain. It's actually just headaches. All right, big ticket items we're going to work through. I got my agenda up. If you guys are switching slides, I'll give you 2 extra seconds to get there. All right, so the 2 big categories we're going to talk about today is our primary headaches and our secondary headaches. And a lot of these are words that we should be familiar with just from like, I know what a migraine kind of looks like. I know what a tension type headache. They're just kind of lay terms and you can use that knowledge. They're not like crazy, like, no, it's completely different from what you thought. Start with what you know because you're going to see these in clinic a lot. For my people that have worked in clinics before, you've seen people with migraines, you've seen people with tension type headaches. Take that knowledge going forward. This is pretty straightforward things. And then we'll talk about some secondary headaches. And then I put this in here just to kind of wrap up like what the big overarching things are within that. If you look, a lot of our primary headaches, those are headaches where the headache is the disease. There's nothing underlying that's actually causing me to have a headache. That's a little more reassuring, but migraine headaches can still cause a lot of disability. Cluster headaches, also known as suicide headaches, can really knock you on your butt. So even though these don't have like a scary underlying etiology, don't take these to be less severe because it can cause a lot of disability and require treatment. Now, secondary headaches are where I have a headache, but it has some weird features to it. Who remembers a mnemonic? Maybe not so much the words, maybe just the word. What's a good way for me to differentiate the 2? Snoop. Snoop is the one I want. Pounding, it comes up in a second here for the migraine headaches, but Snoop is my one that's going to tell me the difference between the 2. And I have a slide for you later that shows that. I think it kind of references here. If you look online, like there's like 4 or 5 different versions of Snoop. People keep adding things or changing what the O's refer to. Just kind of keep a general older onset. If it's 50, if it's 60, don't drive yourselves crazy between different guidelines. It's more a mnemonic to help you recognize, hey, there might be a secondary reason. But look at these secondary reasons with me for a second. You guys want any of these ones? I don't want a vascular disorder. I don't want the giant cell arteritis. I don't want that. None of these are great things to have. So that's why we're kind of ruling out the more scary underlying things before we jump into a diagnosis of primary headaches. Are you guys familiar with the idea of diagnosis of exclusion? We kind of talk about that with IBS where it's like, hey, it's definitely fitting this picture, but I have a whole bunch of scary stuff I need to work through. We kind of do that here where we say, hey, you have a weird new headache. It sounds like a migraine, but there's a ton of scary things we got to rule out first before we call it that, because as soon as we label that, we stop looking at the scary stuff. All right, primary headaches. Who's had a migraine before? Yeah. Not fun, right? Cool. Who's had a tension type headache before? Everyone should raise their. If you never had a headache in your life, God bless you. Everyone in their adult life has had a tension type headache. I've been hungover once before. I will be again. All right, migraine headaches, very familiar. Patients will say they have migraines, and they mean they have really bad tension type headaches a lot of times. And we'll kind of go through some of the differentiators. And I'll tell you my clinical approach. It originally had like crazy diagnostic criteria. Don't drive yourselves crazy. I'm going to give you how do you talk to patients to actually differentiate those. And then we have this last one down here. It's called cluster headaches. Has anyone ever seen or heard of those before? Has anyone ever seen it before? They're scary when they happen. They're kind of like the 1%, but they're very severe in nature. Okay, let's jump into migraines first because that's a fun one. So this is the second most common cause of headache in the U.S. About 15% of women, 6% of men will be affected. You will have active duty soldiers and or guardians or war fighters of various capacities that will have this. Typically, migraine is a recurrent primary headache disorder associated by nausea, photophobia, meaning we like to turn off the lights because it's very painful for us to be in there. Phonophobia, loud noises bother us a lot, and then some sort of functional disability. When you have a tension type headache, you can go to work and exist, it sucks. When you have a migraine, no, you gotta go into a dark room and exist by yourself for a little bit. And then their neurologic exam is typically normal in between attacks. We don't see a lot of weird findings with these people. And we recognize it by triggers. A lot of times people will have a migraine headache brought on by something particular. It could be a certain smell, it could be a certain food, it could be sleep deprivation. And recognizing that trigger with the patient is key because that's how we actually avoid the migraine headaches from happening and having to reach into a lot of pharmacology. All right, different ones. Lack of sleep is a very common one I see in the military. If you need to write a profile for someone to say avoid 24-hour duties if possible, don't be afraid to do that. Do not write a permanent profile that says may show up to work at 8 o'clock and leave by 1600. That's crazy talk. All right, triggers are specific by the patient. Headache diary can help a lot kind of differentiate some of these things. I think I brought the slide up a little earlier. It's on this next page here, but this is what aura typically looks like. Has anyone ever seen this before? As it happened, I guess that's the only way you've seen it when it happens to you. It's very bizarre when it happens, right? Is it kind of like moving very rapidly when it does? Or does it just kind of sit there on the side? You notice the blind spot as well. So we see, this is called scintillating scotoma. I'll show you the image because it's good to describe it to patients when you say, oh yeah, migraine with aura. It's like, if you have it, you know. This is actually what it looks like in a lot of people. It tends to occur on the outside of visions, can occur centrally. Sometimes we have this vision loss here where things are just kind of grayed out. It's very noticeable. You can like see it. And I think it happens between both eyes in some people. It kind of presents a lot of different ways. You can't see anything, eye just goes out completely. It's annoying for the patient because you're like, hey, I want to focus on something, but my eyes won't let me. I can see it, but I can't. But this can be very active when it happens. Typically occurs anywhere between like 5 minutes to 30 minutes, up to an hour before an actual true migraine occurs. Sometimes we call it ocular migraine if we just have those findings in general. But just remember what this picture looks like because it helps to describe it to a patient because they'll say, I can't see. And you're like, oh, is your eye out? It's like, no, there's a bunch of weird stuff. And you describe it to them and you're like, you see what I see. And you're like, yes, I've seen the picture before. Or for my people that have experience to show them where it is, and they'll be like, yeah, 100%, that's what I got going on. All right, so the exact causes of most of our primary headaches, it has a lot of different things in here. We don't know exactly what precipitates a migraine headache. There's a lot of different theories that involve a lot of different neurotransmitters. Don't get too wrapped up in the weeds to say, this is the cause of a migraine. You can describe some of it, but again, literature is gonna point you in a million different directions. Same thing with tension type headaches. Reason why we brought some of these stuff up is there's a medication, CGRP type medications that work really great for this. It's calcitonin gene related peptide. Basically, it controls inflammation and vasodilation versus constriction in the brain. When we go after that target, we have much better effects. So that's why we brought this one up. Serotonin is kind of involved too, and that'll involve like some of our different treatments. That's why people tend to get a lot of nausea when they have migraine headaches because that serotonin goes up through the roof, and that's involved in our chemical trigger center a lot of times. Dopamine is in there too. We have a couple of medications that affect dopamine, but again, we're kind of guessing when we're actually talking about what exactly is going on. But just for general like idea of what's happening with a migraine, whole bunch of different neurotransmitters. I got dopamine, serotonin, CGRP, different things are flowing through my brain with a ton of inflammation and a ton of changes to vascularity that's causing my brain to not really fire right. Not to the point of having a seizure, but thinking can be slowed down. I can have a lot of very strange neurologic symptoms as a result that resolve spontaneously. Some people get aura, some people don't. Most people don't. Typically a migraine can last anywhere from 4 to 3 days. Has anyone ever had a 3-day migraine? Just disappear for a few. I've seen 1 or 2 last pretty long. Usually they go to the ER when you wake up with a migraine again. They get diagnosed with status migrainous. That's a migraine that doesn't go away. But unilateral, pulsating, moderate to severity, worse with activity. I usually describe what a headache looks like to a patient when they say, I have migraines. And I'm like, is it one-sided or both-sided? Is it cause nausea? These things. And I describe both headaches and they say, it's more that one or more that one. That's my really good way of differentiating clinically if it's a tension type or migraine type. And then migraine with aura, again, we got like a demonstration of scintillating scotoma. It's not always visual. I think the fully reversible was meant to be up here, but gradual onset, about 5 minutes to an hour, fully reversible visual field deficits, sensory changes, speech and language, motor issues, brainstem, whole bunch of weird symptoms that are going to present like a TIA. And sometimes those get assessed as TIAs, as you should if someone suddenly can't find words anymore or has sudden visual loss that's painless. All those things require urgent evaluation. Don't just assume it's migraine with aura until it's fully worked up. Now, every single time someone has migraine with aura, does it need a repeat workup? If they're having a lot of motor deficits, maybe. Probably see neurology before that point. But if they're having the typical scintillating scotoma, I don't need to reevaluate every single time. I think we were mentioning the pounding mnemonic a second ago. Don't worry about memorizing this one. Just be able to clinically recognize the features of a migraine. This is helpful if you're just like, I don't know what a migraine is. I've never had it before in my life. People that have had migraines, they can describe it to other people. But if you've never had one before, I think pulsatile onset is typically about 4 to 72 hours. Usually unilateral, but it can affect both sides of the brain. It's not always 100%. I can have some nausea and it's disabling. I can't go back to work with a migraine headache usually. I can try, it's just not fun. All right, if you've had migraines, you can have chronic migraines. So we define this as 15 or more headache days, and that's not just migraine headaches, that could be tension type or any kind of variety in between, with 8 or more of them having some sort of migraine feature. This number is important because we start talking about medication overuse headaches. I have certain abortive medications which help me get rid of a migraine from happening. If I take those more than 15 times in a month, I'm going to start having a lot of issues with taking that too much. So if I get to the point where, hey, I want to give this guy abortive therapy and stop doing these things, start thinking chronic migraine issues. The reason why we care about chronic migraine is that opens up a whole new class of preventative medications. I'm not just dealing with, hey, you have a migraine once or twice a month, just take this pill whenever it pops up, versus you have migraines multiple times a month, you can't take this pill that much, let me give you this additional medication that you take every single day to prevent it from happening. So normal exam outside the attack. When you have a migraine, for my people that are migraineers, are you guys happy looking when it happens, or you look pretty gnarly? People don't look good. He does not look good. He gave me the thumbs down. All right, imaging not always needed, but I always do it if it's new. And I get a lot of people presenting with, hey, I have this headache, but it's causing weird symptoms. And it's like, hey, is this your normal headache you've had for a long time, or is this new and exciting? They go, new and exciting. I'll send them off and get a brain MRI. It doesn't need to be urgent. It could be within the next 30 days or so, but I'll do a ton of brain imaging for new onset of migraines because typically people don't develop it in their 30s. A lot of times people don't have access to healthcare before they join the military, so then they present and they said, I'm healthy at MEPS, and all of a sudden they have migraine headaches, and you're like, okay, fine, just go get the imaging. I've never gotten a brain MRI and been mad about doing it. It's perfectly warranted for new onset of migraine headaches. And if the patient says that's what happened, cool. Atypical, if I have a lot of very weird neurologic findings associated with it, it's outside of that just normal scotoma that I feel comfortable about, go get the imaging. Even if it's completely resolved from a while ago, make sure there's not a structural deficit. And again, focal deficits, pay attention to that. I saw this post on Reddit that kind of made me laugh. Who's ever seen a patient in a dark room before? Or they show up with the sunglasses and the kind of like the Ray Charles thing going on, and you're like, just you go in there to examine, you flip on the lights because you're like, why are you sleeping? And then they freak out and go into the corner. Just leave the light off. Like, there's been plenty of times where I've interviewed a patient and done physical exam in a completely dark room just because it's very painful to have a migraine ongoing. And if you know they have a migraine, they have the sunglasses on, go flip the light off and just leave the door cracked so you have enough light to see what you want to do. But they were saying, shout out to my neurologist, dark section of the waiting room. They even turned the light off for them. So be the good provider, allow them to have the light off. Don't be like, no, I need to see and examine you, flip the light on, because that's just a jerk move. You can see what you need to see in the dark usually. All right, let's talk about treatments real quick, and then we'll move on to tension type. First things first, don't worry about memorizing this stuff. I got my migraine disability assessment score, my MIDAS score. For my people that have MD Calc, star this one because it's a really good one to kind of give you a number for how good or how bad their migraines are. I get a score, that's great, but then I start doing treatments, I start doing other things, I can see that score go down. And this is kind of a disability assessment, so it gives me actual, like, what the patient is actually experiencing. So then I can say, hey, we did this medication, your MIDAS score decreased by X amount, that's really successful. Or no, it didn't really change at all, we're not having success. This is a really good way to put numbers to your actual encounters. Neurology loves doing MIDAS scores, you'll see that a lot. And then patient education, treatment plan for migraine headaches. There's no one-size-fits-all treatment plan. There's a lot of different treatment options and kind of varying amounts. I can't give you, hey, just every single chronic migraine patient, give them this thing. Because it really depends on how often it's happening, the severity, how much it affects you on a day-to-day basis. Are we pregnant? Do we have vascular risks? What is our risk for, medication overuse? You have to kind of individually build it based upon what the patient wants and needs. Do that shared decision-making with them. It goes a long way. All right, so we have a couple of non-pharmacological things, and then we have things for acute attacks, also known as abortive therapy, and then we have prophylaxis therapy. That's the biggest way to crowbar separate these two is to say, hey, I got my acute ones that I take when it pops up, and I got my prophylaxis ones that I take daily, monthly, every 3 months to prevent them from happening. Under the non-pharm, I look for my ID triggers, or I try to find out, hey, every time I drink red wine, it gives me a migraine headache. Stop drinking red wine. Thank you for coming to this appointment. We can also give them headache diaries. Has anyone ever seen that before from working primary care clinics as a medic? We always say, hey, do this headache diary, but we don't actually give them anything to fill out. Just go find a PDF form online and be like, hey, I know you got some migraines. Fill this out for me for a little bit. I want to see how often we're being affected. A lot of the times the patients will be able to recognize, hey, wait a minute, every single time it's related to me sucking on sleep. And you say, oh, let's go look and see if we have a sleep study, or do we need to fix your sleep schedule or sleep sanitation? You may find other targets for yourself medically. You can have migraines due to other issues that are easily addressed. And then expectation management, non-pharm, yeah, they can work great to reduce the amount of migraine headaches you're having, but you're not going to work yourself into not having a migraine ever again by just lifestyle changes. If we're having acute attacks, this is kind of your mild to moderate symptoms. It's perfectly okay to stick with like your simple analgesics, whatever your favorite is. Excedrin works really good, just has a little bit of caffeine in these cases. Naproxen, ibuprofen, just make sure you give them the 800, 600 milligram ibuprofens, because like the 200s and swallowing handfuls never really works great. But the thing to pay attention to is acute therapy early, but avoid frequent use. So if we're giving them more than 14 days a month that we're using these ones, eventually you get to the point where your brain is used to having this amount of NSAID on board or this amount of Tylenol in order to prevent pain symptoms, and you stop taking those medications. It's not that you're gonna have like withdrawal symptoms and like start having shakes, but you'll actually develop it to where your brain becomes hypersensitized because you're like, okay, I've suppressed it. Now I like my pain receptor level is a lot higher in the future. So we always be careful if we're doing more than 14 days for the simple NSAIDs, analgesics, or if we're reaching for our triptans. No one's prescribing ergots anymore. You can forget everything about it. Typically between 9 to 10. If I'm doing more than 10 days a month on those, it's overuse. It doesn't allow you to prescribe more in a 30-day period, which is nice, a nice little backdrop for us. So let's say we got someone coming in with migraine headaches and they're moderate to severe. They're kicking them around their butt. We've tried the migraine headaches that fails NSAIDs and they're like, I need something different. It's the Excedrin just isn't cutting it. A lot of times they take Excedrin already, so take that as the initial step. I got my non-selective, they're vasoconstrictive ergotamines and dihydroergot. Yeah, have you guys heard of ergots in pharmacy before? I'm gonna tell you a secret, forget everything about them. No one's prescribing them anymore. I've seen people with the 81 milligram aspirin, just leave them on those ones. If you catch people on ergots, switch them up to a triptan. There's very rare cases where you will not be prescribing these medications. Go to the triptans always. All right, so don't worry about those ones. Ton of vasoconstrictive stuff. The side effects outweigh their benefits a lot of times. There's just a better class of medication. There's no point prescribing those. All right, my triptans. I highlighted my ones that I thought were like, I've seen them in clinical practice a lot. You will get people that are on one of these and they will fight you to death if you try to prescribe one of the other ones. They're like, no, that's the awful, that's the devil's lettuce. Do not prescribe that one. I don't know why. They're all kind of very similar to each other. There's no like, hey, this is the truly superior triptan, but for whatever reason, if someone is on one, they will fight you over the other ones. Just take that with a grain of salt. Sumatriptan, also known as, most people call them the trade names for these ones, and you'll probably recognize them from commercials. But sumatriptan, Imitrex was the OG. That one's like by and far what most people are prescribed upon. If they're on sumatriptan, just leave them on sumatriptan, keep refilling it. Elatriptan is one of the newer ones that tends to be better tolerated by like maybe a few percentage points, nothing too crazy, slightly more efficacious. I'd reach for that one if I'm prescribing new people on it. And then I see a lot of people on rizatriptan and Zomig. That has an intranasal version. I don't really prescribe that one a lot. Some people really love the ODT. Do we know what ODT stands for? Oral dissolvable tablet. Yeah, that works really well for the people that have like a ton of nausea and they're like, dude, I can't swallow a pill when this happens. If someone starts on one, they really don't like it, just switch them up to a different one. You can switch between that same class, and a lot of times people will tolerate it better, but elatriptan's a really good fallback too. But any one of these ones are okay. If someone's telling you, no, this is the one you need to prescribe every time, they're crazy. All right. Who's ever treated a migraine inside clinic? Have we ever done migraine cocktail, or is that kind of foreign? I'll give you, I see one or two heads. I'll talk you through the basics. So you'll get people that present with migraine headaches a lot, and you're like, oh no, what do I do with this person? You can give them an IV bag, and we can give them a couple of different medications. We call it a migraine cocktail that works really good for a lot of people. Toradol tends to be a really good option if they're eligible for NSAIDs to kind of knock down pain control acutely. And then I like to give them something for the nausea, vomiting. That really drives people in with the migraine. You can have a headache. I'm not going to go see doc, but if I'm puking my brains out and having a headache, probably going to the clinic. But metoclopramide, that Reglan, is another really good one for us that kind of helps knock down some of those other receptors, and it takes care of the reason we're having nausea and migraine headaches. So a lot of times you'll see a bag with Toradol in it, a liter of fluids, and some metoclopramide that works pretty good to kind of knock them back down. What's the thing I have to watch out for if I'm giving someone Reglan in an IV bag? Can get that weird dystonic reaction, somewhere between that akathisia, meaning those kind of like twisting sinuous movements, or I may even get that dystonic reaction where I get sudden, like everything's kind of locked up. Pre-medicate them, just give them Benadryl too at that point. It's very common to give Reglan, Benadryl, Toradol in a bag, so that way we prevent those symptoms from happening. And it has a lot of drowsy effects. 2 of those medications can cause some sedation in people. If you have a migraine headache going on, I want to go to sleep. So if I give someone a migraine cocktail, can they drive home? No, two drowsy medications in a row on top of someone already having a migraine, not a good bet. So make sure they have someone that can drive them home. Be like, hey, I can either give you outpatient prescription, you can go home if you need to drive yourself and you're safe to do so, or we can do migraine cocktail. There's various formulations. That's the one I've seen the most. But hey, Toradol bag, add a little bit of metoclopramide for the nausea, throw on some Benadryl to make sure we don't develop dystonia, be feeling a lot better in a few minutes. All right, preventative. So these are more ones that have either increasing frequency, they're unresponsive, poorly responsive to abortive treatments. If we start going above that like 10 limit that we want to see in a month, you're like, I'm having more than 10 migraines in a month, we want to start reaching for preventative treatments. If you start thinking chronic migraine, start adding on preventative. There's only about a 50% success rate with any drug. I've seen people swap between difference and have multiples within this class. I've also seen a lot of people just get some relief with preventative medications and they do a lot better. So I got some preventative treatments. Who's ever seen these ones before? They're old and busted. New hotness. Old and busted. So beta blockers, my old school antidepressants like amitriptyline, and my anticonvulsants like topiramate. Don't worry about the dosages. I tried to get rid of all the numbers because I know that makes us nervous. Beta blockers, what happens if I give a strapping young soldier a beta blocker? Bradycardia, exercise intolerance, erectile dysfunction, they're not going to want to do that. Never seen someone be like, hey, can you refill my propranolol for me? They don't love it. And then antidepressants like amitriptyline, those are dirty, not like dirty as a pill, I dropped it on the ground, but it has a lot of side effects. We intentionally want that because we're trying to hit a lot of different receptors. I've seen people be on amitriptyline and do great for the post-traumatic headaches and sometimes the tension type because these other medications don't work great there. For migraine headaches, it's kind of hit and miss. It's tolerated, but not the best. And then I got my anticonvulsants, topiramate. Paresthesias, cognitive symptoms, weight loss, glaucoma, caution, it can cause kidney stones. People don't love being on topiramate unless they're having seizures. Yeah, neither of these were fantastic. I never had a lot of luck. Sometimes amitriptyline, but none of these were great. They're old and busted. Don't reach for old and busted if you don't need to. New hotness. So these are these CGRP medications. You guys might recognize some of these names like Qulipta, Emgality, Aimovig, Ajovy. Have you guys seen commercials for those or familiar from Farm at least? Farm, we've seen them before. Okay, you'll hear them, like, I put the trade names in there because most of the people refer to them as the trade names and the patients refer to it as the trade names. It's hard to memorize everything as a UMAB or ZMAB and then you see it in real world. For the sake of the pants, it's always the generics. For the sake of our test, I'm gonna put both, if that's okay. I don't think there's any rules against that, but just for recognition's sake, you guys will clinically recognize it by the trade name. We'll do both, but just be prepared for the pants that it's gonna give you those. You guys know how to recognize a UMAB versus a GPAD, right? UMAB ends in UMAB, a GPAD ends in GPAD. All right, so my gene pants, these are the only ones that are good for acute, and some of them fall into that kind of preventative ones. These are typically oral medications. I can use Nurtec for both acute treatment and prevention, used more frequently. I can use Brevly for the acute to stop and as an abortive therapy. And Qulipta, I take that one daily, but again, oral medication's great, but now I have to take a pill every day. And then I have my monoclonal antibodies. That's that Aimovig, that Ajovy, that Emgality. These are all sub-Q injections because my body breaks down antibodies if it tries to enter through my stomach. These other ones are small molecules. You can actually take it orally. These ones are typically monthly injections up to, I think, once every 3 months for a big boy here with the Ajovy. These tend to be a lot more expensive, so just pay attention. How many people here are gonna be active duty? Fantastic, don't worry about the cost. How many people are gonna see real people in the real world? Meaning medical billing and cost of things become an important factor. This will drive it, because some of these things are upwards of $900 to $1,000 a month for dosages, so pay attention to that. A lot of times when we deal with these auto-injectors, where the patient's injecting themselves, that drives up the cost a lot, because that's how they patent these medications. So just pay attention that cost is a factor in some of these things. Even though one medication might be moderately better than the other one, something that they can actually afford, that their insurance handles, is important. So pay attention to these things moving forward. But just kind of a comparison of like, I just picked like a representative, I think that's Ajovy unless I'm crazy. Yeah, oh, Aimovig. So I compared Aimovig to topiramate, and the goal that we're going for by doing preventative medications is about a 50% reduction in daily migraine headaches. When we take preventative medications, counsel your patients early. It's not going to completely get rid of migraine headaches. We're just trying to knock it down to where you're having half of that. Most people with migraine headaches would be super happy to have that. So with, is it Aimovig I'm dealing with here? Yeah, Aimovig. So if I'm dealing with Aimovig, I'm expecting about a 55% of people having a successful amount compared to topiramate, which is about 33. So it's a small percentage change. But then the amount of people that have to stop it, only about 10% of people are getting off this medication versus topiramate, again, is a coin flip whether or not people tolerate it. That remaining 60% of people, they're having symptoms, they're just putting up with it. So it ends up being, hey, the combination of reduction is slightly better, way better tolerated. That's why we like the new hotness, not the old busted. All right. Who's ever seen a prior auth before? Cool. So I just want to do like a quick aside. You can turn your brains off for studying mode for 2 seconds. When we start dealing with these super expensive medications, a lot of times we have to do what's called a prior authorization. This affects us both on the military side of the house and on the civilian side of the house. It's a form I have to fill out that says, have you ever done X, Y, and Z? And you have to walk through the steps in order for them to give a medication. And it'll tell you before you prescribe, hey, prior auth is required. And you say, okay, go online to TRICARE, search their formulary, look up their prior auths, because you can get those freely online from anywhere. I have to fill this chart out and email it in before they'll prescribe them the medication. They usually get back to you in a few hours. It's pretty easy to do. But if I have certain medications that I'm reaching for, I think the one I picked up was Ajovy for giggles. It actually asked me, hey, did you try Emgality first? So I know from a military healthcare perspective, it's not just like nebulous rules of I have to prescribe this one first before I try this one because of cost. You actually have to go into the prior auth forms because it'll tell you exactly like, hey, Emgality is first line because of cost. So go through when you hit medications where you're like, hey, I know I have the prior auth forms, pulls all those offline, go through the steps to actually give it. It may direct you to say, oh, I want to give them this, but Emgality is going to be the cheaper option. I don't need a prior auth to do that. Start with that medication. You'll get better as you go. Don't worry about learning these for class, but just know that prior auth forms exist, and that'll actually change your management in some cases. All right, that does it for migraines. Let's move on to tension type headaches real quick. I think we can make it through cluster and take a break. We started a little late, yeah. All right, tension type headaches. Everyone has had one of these at some point in their life. I don't care what they tell you. All right, tension type is typically bilateral, covering both sides of our head, pressing, tightening, moderate to mild, not worsened by routine activity. I can exist in a normal day-to-day with having a hangover. That's okay. Episodic attacks affect up to 78% of the remaining, 22%? They're just truly blessed. Adonis DNA. No underlying pathophysiology. We don't really have it as well described. Some people have said muscle tightness, the tension of the scalp muscles can precipitate it in some people. That's not 100%. We don't really know what the difficulty is. That way, we don't really see as many targeted therapies like we do with migraine-like headaches. But again, just kind of describing the same using the words. Do most people feel good about the migraine features and the tension type features? Like you could describe it to a patient and kind of differentiate out which. As long as you got kind of like an overarching idea, I won't belabor the point with you guys. But tension type headaches, we should not be seeing focal neurologic deficits, no papilledema, and we shouldn't be seeing these red flags that snoop pneumotic. Make sure those things aren't there before we call it that. Don't go on a crazy fishing expedition. Avoid getting the brain MRIs and like a ton of labs and a CBC and a blood culture, because you end up getting false positives and it ends up causing more harm than good for your typical tension type headaches. Again, tension type headache is favored when there's no nausea, vomiting, yes, all these things. When it's not a migraine, it's a tension type headache mostly. And just more of the same. There's nothing exciting or new here. All right, with tension type headaches, we see the non-pharm, again, behavioral approaches, relaxation techniques, massage therapy, whatever. TRICARE won't pay for that, I tried once. Don't worry, look for the triggers again. We don't see that as commonly with the migraine headaches, but a lot of times behavioral health can help a lot with that too if we see someone being really stressed out and having tension type headaches as a result. And then your simple analgesics again. Again, we want to give them analgesics because they work great, but don't give them too many. It's kind of a balance between the two. Control that with how much you're prescribing and ask the questions of how much they're taking. Because if they're taking it more than half of the days of the month, I'm really worried about rebound headaches at that point. And then avoid frequent use, but prescribe it, sure. It's a balance. All right, and then chronic tension type headache. Amitriptyline works good in these ones. I've also seen it in post-traumatic headache. They tolerate it well and they take it, and sometimes it buys some relief. I've seen people remain on it. There's not a lot of other really good treatments like the migraine headaches for your chronic tension type headaches. Once you get into that chronic daily type headache, have them see neurology because they may have some more options for them. All right, last one is cluster headache. This one isn't as common. It's only about 0.1% of the population, males more commonly than females, but it's excruciating. It's also known as a suicide headache. These people are not well. A person having a cluster headache isn't gonna sit there and tell you they're gonna have a cluster headache. They're gonna be crawling up the walls in the background. The key to kind of recognizing this one clinically, where you're like, is this guy having a migraine? Because they're both kind of unilateral in nature. You may have some like tears associated with having a migraine headache if it's really bad. Migraine patients often want to lie still, but cluster patients will often pace, rock, or appear agitated. They're going to be moving around the exam room because they're in so much pain. Typically, it's very short in onset, about 15 to 180 minutes. The reason why they're called cluster headaches is they tend to happen in like clusters with each other. So you may have up to 8 episodes a day of just like the worst pain in your life screaming, and then things are going normal, and that may happen a couple of times a day. These odd numbers were just taken from the diagnostic criteria. Don't worry. It's like, what if they have a 9th one per day? It's like, no, it still fits within it. And then nocturnal onset, well, 50% of patients. If we're waking up from sleep with a headache, is that kind of a concerning feature? It doesn't happen to most normal people. Pay attention to that one. And then it's usually associated with some sort of autonomic dysfunction. That's typically your conjunct. They may have a really red eye, lacrimation, oral fullness, their nose might be running, they might develop this ptosis. Pay attention to those, but if they're having like a ton of episodes of those back to back, it definitely fits a cluster type headache. Treatment for these ones is actually high flow oxygen with non-rebreather mask, which is super easy to do. You just grab it off the wall, put it on them. I've seen a couple of people with cluster type headaches where they actually had the setup in their car for high flow oxygen, and they just run back to their car and sit there with the gas. That's the face I made at him. He was very odd, but he actually had a high flow oxygen set up for treatment in his car. And then preventative treatment, they like verapamil. Just make sure you're getting an EKG before we get people on that and start titrating them up, because you may be at a higher dose than what you normally expect. But here's a wrap-up slide. We'll take a break in 2 seconds. We covered migraine headache, tension type headache, cluster headaches. And if you guys want to take 10, let's do it now. For a few extra seconds until people find seats. So from a PCM's perspective, as far as what you guys should be comfortable handling versus when to refer to neurology for some of these headache syndromes, I got really comfortable handling my migraine headaches from diagnosing it to treating it with some of those abortive therapies. And if they did well with that, occasionally I get imaging if they had atypical features or was something new. I'd send them off and get a brain MRI on my own. Just like 30 days later, I get a result. I'm like, cool. And if they do really well on that abortive therapy alone, and a lot of people are managed fine like that, like about 45, I'd say about like 80% of my patients fit that bill. I just keep them at that level. They wouldn't see neurology. If I got to the point where I wanted to reach for some of those prophylactic therapies, get them on a daily medication, a lot of times I'd start saying, hey, we tried abortive therapies. I got neuroimaging done. I'm still thinking to the point where we need some additional control. I'd usually send them to neurology at that point. A lot of those different injectable medications, if you look on that prior auth form, it's back there, I'm not going to drag you all the way back, but it actually has a box check to say is prescribed by or under the direction of a neurologist. And you're like, okay, these are very expensive medications that I don't want every known PCM prescribing to people showing up with headaches because it's going to cost way too much. A lot of times if I get to the point of wanting preventative medications to skip having to go through that old notness, that old and busted, I probably send them to neurology, not bother doing the propanolol or the amitriptyline. And then for my tension type headaches, I hang on to a lot of those guys. But if I get to the point where I have something that's called chronic daily headache, I think is an older term, but if it's to the point where they're having more headache days than not with those tension types, even though they're mild, they're just having a headache every day of their life, I send them to neurology too at that point if I kind of fail those prophylactic therapies. I don't put a ton of them on amitriptyline. If someone's having more headache days than not, even if it's tension type, I send to neurology at that point. And cluster headaches, I'm probably talking to a neurologist. I haven't seen too many. I don't think I've seen that in clinic. I've only seen one person with that was like a physical therapy. But all right, let's jump into our secondary headaches. Our primary ones, the headache causes the headache. The secondary ones, something else that's scary is happening. We like to use the Snoop mnemonic as we've talked before. Don't worry about memorizing it, but ask these questions when you see someone with headaches. Your medics won't always automatically do that, but if you train them well to say, hey, go through Snoop with these guys and hand them the sheet, they can ask these questions ahead of time for you and save you a lot of time. All right, temporal arteritis, we've covered it a few different times. Inflamed temporal artery, older dude, typically, I think it's women more than men here. I thought that was different from before. I apologize if that's off. But most commonly after the age of 50, mean diagnosis typically about 70. Look for the elevated CRP. Big takeaway from this one, over the age of 50, new jaw, claudication, scalp tenderness, vision symptoms, treat urgently. Don't wait for the temporal artery biopsy. I think we've already tested on this one, so unless anyone is okay with it, I'll move on from this one and not belabor the point. And then biopsy, don't delay steroids. We already asked test questions on that one. I'm not going to repeat a GCA question. The PANTS loves doing it, and we kept it in with the headaches because it is a common cause of secondary headaches. All right, next one we got is idiopathic intracranial hypertension. More commonly, you'll see the word pseudotumor cerebri being used. Pseudo meaning fake tumor, as in like it behaves like someone has a brain tumor initially because that elevated intracranial pressure, cerebri meaning brain. But idiopathic also meaning we don't know what causes it. These are people that just have a sudden increase in intracranial pressure, like over an acute days to months long period. Classic patient, we're looking for young, overweight women. It can happen outside of that demographic, but it's easier to kind of recognize it. I think this is the image that was here when I was an IPAP, like just to make you think of this one. But think young, overweight woman with headache, pulsatile tinnitus, meaning that ringing in the ears, papilledemia, transient visual obscurations, and possible cranial nerve 6 palsy. What does cranial nerve 6 control? Eyes going out. So if the eye kind of gets stuck going out, or if I have horizontal diplopia as a result, think of those ones. So typically affects younger, middle-aged women, overweight, possible menstrual irregularities, often idiopathic. When we have our intracranial pressure being too high, when we lay down, it gets worse. And that's kind of atypical compared to your average headache. Someone wants to go lay down and not exist for a little bit. These ones want to sit upright because it's going to cause less of that pressure. It's going to pull some of that off the brain. But we're going to see papilledema. Make sure you look inside the eyeballs, especially in those weird headache presentations. Rule out papilledema because we do see this in the ER somewhat frequently. It's not one of the more rare ones. We like to get MRI in these cases. Anytime we think, hey, we may have elevated intracranial pressure, get imaging. Don't get the LP first because that can cause herniation if things look like there's a mass effect. But if it looks clean, we do the LP. They may see that elevated opening pressure. That's going to be your diagnosis right there, is that elevated pressure on LP, because everything else is going to look normal. And then as far as treatments, weight loss can help with that. Acetazolamide, did you guys get exposed to that in pharm? I know that was like one medication that I ended up using more frequently than I thought I would, and it was like way underplayed in pharm. I liked using it for altitude-related things, but it's a carbonic acid anhydrase inhibitor. But this is going to help work great to kind of reduce some of that pressure for us. So acetazolamide, aka Diamox, is great. Topiramate might be helpful too, but acetazolamide, just keep that. It's like the weird medication that pops up randomly. But here's the place for pseudotumor cerebri. Remember that one. That might be on a test. And then people that are having vision loss issues as a result, they may take them in and do what's called optic nerve sheath fenestration. That's where they cut. Fenestration is a window. They cut little windows in that nerve sheath in order to reveal some of the pressure. I think juniors are going through ortho right now. You guys aren't. You guys familiar with a fasciotomy where someone has like compartment syndrome that can relieve some of the pressure? Very similar procedure. Do not look, I found a picture online of it and I said, that's too much. If you want to look it up on your own, go ahead, but they take the eyeball out and cut fenestrations into it. It was one of the more gnarly procedures I've seen. All right, intracranial neoplasm. We put this in here. We don't really cover like brain tumors as like an entire lecture because it's not something we deal with in primary care settings a lot. We'll introduce some of the concepts of it, but we're not expecting you to diagnose and treat a brain tumor from start to finish. That would be way too much detail that's outside of the scope of what an initial PA should be. If you end up in different specialties, they'll kind of treat you some more things like that. What I guys want you to be able to do with brain tumors is be able to recognize the initial presenting symptoms, because you guys are the sensors out there as PCMs in the world to say, hey, I'm concerned this guy has a brain tumor. I can at least recognize it. Do I need to know the specific radiation treatment that works with this very specific type? No, we're not going that far into the weeds. I thought it was weird. It was like, why is brain tumor covered under headaches? It's because we want you guys to clinically recognize these things. About 30% of patients will have their headache as their first symptom that have a brain tumor, and about 56% of patients will endorse having headache at the time. It may be an additional finding. Headache from a mass lesion is often progressive. Usually when I have a headache syndrome, it kind of stays the same. But if my headaches are progressively getting worse and worse, lasting more days, pay attention to that change because there's something driving that. Worse in the morning, waking up from sleep. We don't typically get headaches when we're asleep. Pay attention to that one. That one's always concerning. Worse with exertion or Valsalva. Most people with migraine headaches aren't going to want to work out more, but if your headache suddenly becomes disabling because you popped your ears, that's a concerning feature. And often associated with nausea, vomiting. Same thing with the migraine headaches. Just always pay attention when you're dealing with migraine headaches that, hey, this isn't a secondary headache. So intracranial neoplasia, brain tumors kind of present in three different flavors. It might be a progression of a focal neurologic deficit, then a young person that shouldn't be having a focal neural deficit. They may have new onset seizures as an adult. That should always raise red flags. And lastly, these non-specific, this is where kind of that headache fits into, where you get headaches, then all of a sudden dementia develops and personality changes. But we get new onset of seizure, focal progressive neural deficit, or personality changes plus headaches should raise concern for structural brain lesions. Some red flags. New cluster-like is always scary. Abnormal neuro exam. Progressive headache. Again, just kind of repeating the same thing as before. I apologize for that. Imaging, it's what we like to do. Make sure we avoid LP in these cases. It's not like, oh, we don't see mass lesion. Now you have a mass lesion. Don't do LP in these people because, again, something's pushing with that brain tumor being there. I don't want to cause uncal herniation from that happening, and there's very little clinical value in doing an LP in this case. But just kind of a breakdown of like what the initial presenting symptoms in brain tumors typically look like. Headache is going to be the number one, followed very closely by memory loss, cognitive changes, motor deficit, language deficit, seizures is up there. All those kind of sit within the upper third. If you start seeing combinations of these, that should really raise your suspicion of index. Papilledema, some of these other lower cause ones, don't pay attention to those as much. They can present, but if I got like the 5% case, I'm really like trying to tie together these top 4 or 5 to say, hey, this kind of sounds like a brain tumor in addition to this headache that's here. And then we have a lot of different words to describe different types of brain tumors. It's always a little confusing because someone say, oh, he has an astrocytoma, and you're like, I kind of remember what that is. Don't worry, most people are like not super familiar with all 9 different categories of brain tumors. That's fine. The reason and the way we name these brain tumors is the tissue that they arise from. And the easiest way to kind of break it down is in thirds. I have my glial tumors, my non-glial tumors, and my METs. So my glial tumors, these are my support cells. These are the cells that help the nerves actually do their thing, because most nerves don't have a metabolic function of their own. They need those support cells to keep them going. If it arises from those ones, it's called a glial tumor, and that's about a third of cases. If it's from the nerve cell, the nerve tissue itself, those are typically non-glial cells. And then my last third is going to be my metastases. I see that a lot of time in brain tumors. Brain likes to collect a lot of things. There's a blood-brain barrier there. It filters a lot of things out. METs is a very common cause where the cancer starts somewhere else and it develops in the brain from travel through blood. That's about the level of detail. Do not worry about memorizing all these different ones. It's just kind of like you may recognize these terms as different things describing a brain tumor of some variety. Each of these have like a different treatment plan, prognosis. Some of them are scary, some of them are more common. This is outside the scope of this course. All right, let's cover medication overuse headaches, also known as medication withdrawal headaches or rebound headaches. So if we give someone too much Excedrin, more than 15 days per month, for greater than 3 months, we might start having issues. Some of the very common medications that can cause that, opioids in addition to classical withdrawals, you may get those headaches as a result too. Barbital-containing products, what would that be? Do you guys know Fioricet as a term? We don't really prescribe that one much anymore. It was like Tylenol plus some type of like barbiturate. And it worked great because it made you tired and sleepy, made the headaches go away, but people were actually getting addicted to having that type of stuff on board. But we really don't prescribe Fioricet as much as we used to. Avoid that one if you can. Combo analgesics can cause more issues, especially if we hit them with the Tylenol/ibuprofen combo. That can cause it to happen a little more frequently. And then triptans or ergotamines. We really can't do the triptans outside the 10 per month because TRICARE just won't let you prescribe that many. And then Tylenol, caffeine-containing products can cause issues too. Just pay attention to those ones. When we see this happening, we got to talk to the patient and say, hey, you've had chronic headaches for a long time, but it's the meds now that we're taking that are causing the issues, and we need to switch up what we're doing. Withdraw the overused medication. It doesn't make sense to kind of slowly, stepwise them off unless you're dealing with opioids where you can actually have withdrawal symptoms, then that needs to be controlled. Everything else, pull it out. Don't kind of like, all right, we're going to walk you down because it's just going to make the headaches more protracted. But we bridge them over to something else. It might be that, hey, I was doing abortive therapy with them, but it was too many times per month, and I should have had them on preventive therapy for migraines to begin with. Get them on the preventive, and then take them off the abortive or switch them to something else so that way they're not precipitating it. But it's kind of an indicator that, hey, I should have gone to like amitriptyline, or I should have gone to my newer medications. I should have done something different. All right, meningitis and encephalitis. You guys kind of covered meningitis during infectious disease, correct? You guys haven't had ID yet. It's the juniors that have had this one. Okay, for the sake of this course, we're not going to go too far into the treatment. I know there's a ton of slides in it. They've already had it. You guys haven't, so you guys are disadvantaged youths in those ways. What I want you guys to be able to grasp from this is be able to clinically recognize meningeal signs. Is that okay for people for limits? I think we're kind of familiar with some of those anyway. But meningitis is a meningeal inflammation, that's the surrounding tissue of the brain. Encephalitis is where the actual brain parenchyma, meaning the like meaty tissue of the brain, that's where the meat's affected. All right, meningitis, leptomeninges, can be caused by bacterial, viral, fungal, or other. Bacterial is kind of the big one we're worried about. That tends to be the most common. That tends to be one of the more deadly. It causes throbbing, bilateral, occipital or neutral pain, meaning the back of the head, worsening by sitting upright. We're looking for fever, stiff neck, altered mental status. That should be, I think they have the actual clinical triad in an upcoming slide. But if I start to see these, headache with the stiff neck and they have a fever, really should raise your suspicion for meningitis. Mental status change is also very common with these. When we get someone with meningitis, don't worry, you'll get this during ID. This is just kind of a quick overview. I'm not going to ask questions on management of meningitis for this course. We deal blood cultures and empiric antibiotics pretty quick, plus dexamethasone. That's a steroid for those playing at home. Again, we want to reduce inflammation as much as possible. In these cases, greatly improves outcomes by having that on board. We're going to do a lumbar puncture for CSF diagnosis when safe, and we have our contraindications that we've tested on before, so don't sweat those too much. And then we're going to do the CT before LP if we see mass effect, papilledema. A lot of them are going to present with new neurologic deficits. A lot of them are going to present with altered mental status. Don't be afraid to get that CT ahead of getting an LP. The ways we actually get meningitis, we can get it through the bloodstream or we can get it through direct continuous spread. This is pretty straightforward. It's in our blood. It affects our brain at some point. We have a blood-brain barrier that sorts a lot of things out, but it's leaky. But direct continuous spread, has anyone seen, we've both had ENT, right? Were we ever taught the deadly triangle? Oh, this is a good one. So basically there's this idea that anything within this triangle here, from like the bridge of the nose down to the corners of the mouth, there's a lot of potential for direct spread for infections here, because there's blood vessels that kind of communicate back and go through an area of the brain that's very easy to access to. Treat this as, hey, I have an infection within this red space here, my danger triangle. Start thinking, hey, it's not just sinusitis. I got to watch out that this doesn't spread to the brain. I should treat this a little bit sooner. Any infections occurring here, pay attention to this, because direct spread does happen from this. We can see it with sinusitis and otitis media too. I know that's outside the triangle, but this has a lot of veins that like to travel along this area, can spread back easily. All right, classic triad for you guys, classic. I'm looking for fever, I'm looking for headache, I'm looking for neutral rigidity. And I might be missing one of those. So even if like, hey, I got this guy with a headache and he can't move his neck, but he doesn't have a fever, still call it meningitis. You may have two of those is bad. All three definitely dealing with meningitis. I think the sophomores have been exposed to this in clin skills, correct? We've gone over Brodzinski's and Koenig's sign. Do you guys need this reviewed, or are we good? We're good? Okay, if anyone wants to do it with me after, just let me know and I'll do it up front here on the break, not to disadvantage anyone. All right, big causes. I know we always talk about Neisseria meningitis because we deal with the vaccines for that anytime we're going off to college or doing the military. This one likes to hang around certain populations and like young adults. It just likes to happen in enclosed spaces, but by and far, strep pneumonia is the most common cause of it. So just pay attention to those ones. And listeria is another important one for us. We pay attention to that in our older adults, pregnancy, alcoholic, immunocompromised, maybe all three. If we're dealing with listeria, we want to add ampicillin coverage. And I'm going to step back from, I know I have a couple of treatment slides coming up. We're not going to test on exact antibiotics. One, you get that in pharm, one, you get in ID. But just remember to add ampicillin, amped energy for my people that are going to be at risk for listeria. Does that look like normal cerebrospinal fluid? How often have we seen it? It looks kind of murky. It looks like your car when the coolant mixes with the oil and you're like, no, it's not good. That's not a good look. So in bacteria, we're going to see a high opening pressure. We're going to see neutrophils. If we see neutrophils, we think bacteria. What's the other one that makes us think virus? Lymphocytes, probably not bacterial. And then I see high protein, low glucose. Why do I see low glucose? They're eating it, and it looks like it looks purulent. That's not a good tap to see. Do not worry about this. You guys will get this during infectious disease. You guys will get this during pharm. I'm just going to go over it briefly to make sure if there's any gaps, I haven't gone through those to say, oh yeah, they're definitely taught how to treat meningitis. I'm going to give it to you here once. I'm not going to test you on it. Just kind of pay attention loosely in the background. So 1 to 3 months, we're doing ampicillin plus ceftriaxone. I highlighted the top one because it's easier to recognize. If I see a list of drugs, I just grab the one that I know that I have always and most is recognizable, so I'm not memorizing long lists of drugs. But do I want to give vancomycin to a young child? No, I want to avoid that one. That just kind of clues me into reach for the ampicillin plus ceftriaxone. Can I treat any of these age groups with just one antibiotic? I have to put two on everything. So ampicillin plus ceftriaxone. We know ceftriaxone because we've covered antibiotics in pharm, right? We kind of generally recognize that as, hey, this works great for CNS infections. Today we're talking about CNS infections. So for my vast majority of people, I'm reaching for ceftriaxone plus vancomycin. That's going to cover a huge age range. Once I start dealing with those older people, people with alcoholism, or some type of other comorbidity, I'm probably going to add that ampicillin back on. And then as I start dealing with impaired cellular immunity, ampicillin plus kind of my later generation cephalosporins plus vancomycin. Dexamethasone should be given with that first antibiotic dose. Have we covered like how antibiotics work in the real world with like suspect someone has meningitis and I put them on like a ton of broad spectrum stuff? What happens next is they typically go up to the ward, blood cultures come back, and they say, oh, it wasn't actually this. They'll step them down in antibiotics for you over time. So don't be afraid to reach first and say, hey, I'm pulling the meningitis alarm. I'm starting you on antibiotics. That's okay. They can walk them back down after time. It's way better to deal with that than deal with a missed meningitis. So Neisseria meningitidis, it can cause this weird purpuritic rash that happens on legs. Test questions love showing this picture and saying, what's the diagnosis? It's kind of straightforward. Have we seen pictures like this before during physical exam findings, or is this kind of a new first time seeing this? Maybe new first time, I see some nods. Just recognize this as like a classic clinical picture. You can't talk about meningitis without showing this one. Poor guy's legs, they're just showed in every medical school. All right, don't delay treatment. Even if we can't do the LP because we're waiting for a CT or we're transporting or other things, get the antibiotics on board, get the dexamethasone on board. Don't wait for it to happen. Ideally, it should be within 60 minutes of presenting to the ER if we suspect someone has meningitis. Viral meningitis, and just separate this out in your brain. It's only, I think, 2 slides or 3. It's different than your viral encephalitis. We'll spend a little bit more time there. Both of them caused by viruses. Different viruses can cause it. Symptoms are a little different. I'm not going to ask you to differentiate viral meningitis versus a viral encephalitis. So viral meningitis, not really as reportable. It's a little more self-limiting compared to a bacteria. Enterovirus is common. Arthropod virus can cause some issues. Typically happens in summer and fall. We don't really talk about this one as much, but I'm seeing that lymphocytic pleocytosis, meaning there's a lot of little hypersegmented things in here. I'm thinking something viral is going on when I get a tap like that. And it's primarily symptomatic. I don't have to put them on a ton of antibiotics. If the cultures come back clean and I pulled the meningitis alarm, we can walk them back down and treat them symptomatically. That still might be a lot of support. That might be ventilator support potentially. So don't think, oh, it's just conservative management, send them home. No, they may be ICU with support for a little bit. Some people do really well, like younger kids, typically pretty good. But once we get to the extremes of age, delayed diagnosis, or they come in pretty obtunded, those people tend to do a little bit worse. But there's a lot of variety with viral meningitis. All right, last 2. I think it's like 5 or 6 slides left. You guys are doing great. All right, encephalitis, most commonly viral. Herpes virus tends to be a really common one. Enterovirus can pop up with fecal to oral transmission. Arboviruses, we've all heard of like West Nile virus before. I grew up in the Northeast. That was like a constant fear. It was like other people have dealt with that before too. You just like get bit by a mosquito, all of a sudden you have encephalitis. It's not fun. Viruses directly invades the brain and spinal cord or can spread from other areas like that HSV one, but these are kind of the more common ones. Has anyone been to Europe before? It's a really dumb question, but have you guys heard of like tick-borne encephalitis? A lot of places are very regional as far as what their encephalitises are. Like West Nile virus was huge in the Northeast. If you go over to Europe and you're playing around the woods for whatever reason, tick-borne encephalitis is really common there. They actually have a tick-borne encephalitis vaccine you can get potentially. But just pay attention, a lot of these encephalitises that you're getting bit by different mosquitoes and stuff, it tends to be regional and you're like, oh, I'm aware that this is a thing in this area. All right, labs and tests, get the head CT before you do the LP, make sure you don't have the mass effect because you get that signs and symptoms, you're like, hey, there could be increased intracranial pressure, get the CT first. MRI is more likely to show abnormalities than a CT. It's just going to soft tissue, but MRI might show that temporal lobe involvement in HSV encephalitis. EEG, I've seen this pop up a bunch. I'm not going to ask too many questions, but the PANTS likes to throw this in here, diffuse slowing, meaning those waves of like, hey, I can't figure out why. There's not a lot of really good clinical cues for me to write questions at my level to say, hey, this is encephalitis compared to everything else, but they love cluing in on these EEG patterns of like kind of diffuse slowing. I think for the things that we've studied, we didn't really clue into many EEG patterns, have we? I didn't want you to differentiate. This is the one time I do want you to pay attention to it. And then that CSF, there's additional studies we can get on that. We may want to do a PCR for herpes virus, and make sure you throw that in there, add it on. If you bother to go get a spinal tap, order all the things with it. If I make someone poop in a cup, order every single lab I know how to do with that. General management, again, the viruses tend to be self-limiting, but that can still be pretty severe. They might need a lot of management. Nutrition, avoid secondary infection, treat the fever aggressively, manage your intracranial pressures by elevating the head of the bed. You might consider diuresis with mannitol, seizure precautions. You may put them on anti-seizure medications for a little bit if those start popping up. And then the only big treatment that's different compared to everything else, maybe clue into that because everything else is kind of mush, is this idea of starting them on IV anticyclovir, especially if I'm thinking herpes and herpes virus. They may have a past medical history of it, or maybe possibly Hutchinson's sign or something obvious that says, hey, I'm more concerned with these ones. Not that Hutchinson's sign clues you into encephalitis, but some sort of presentation of herpes. Pay attention to that for like, hey, maybe I should just start them on acyclovir at this time. All right, last one's easy. Sinus headache. Pretty straightforward. We've had sinus infections before. Nasal discharge, might also have fever, sinus pain, tenderness. They have really gnarly headaches as a result. Treat the underlying sinus infection. Don't get lured in by headaches and say, oh, I missed this obvious sinus infection. You can get a CT, probably don't need an MRI, plain film, no, don't get those. Just get the CT, especially if you're worried about people's sinuses. That shows up great. But migraine can commonly be misdiagnosed as sinus headache. Look for that nasal discharge. That'll clue you in every single time. But treat the underlying condition so that way they don't have a headache. This is one of the non-scary secondary headache types. But I kind of threw a wrap-up slide in there for you guys. You can go over that whenever you want. I put in like kind of the high-ticket items, things that differentiate it. That will help keep you straight because I know that was a lot of slides to go through, and we are Dunskies. All right, as far as tomorrow, it's going to be a quick lesson on TBI. And then I believe the day after that, we're going to do a review. We'll do kind of a very similar. I think last time I didn't allow you guys to record. I shot myself in the foot because someone wasn't able to attend. Do you guys want to record the next one? Would that be helpful? I don't want to disadvantage people that, I'm a very auditory learner. If I explain something, I assume people learn the same. Not everyone is like that, so we'll allow you guys to record provided no one's sharing it to the next class. Thank you, I appreciate you guys. We'll plan to do that. Is there any other questions for review or upcoming class? Fantastic.